Hello,
Good
I
morning.
am Heather Montross, Outpatient Manager for Behavioral Health, and I'm here with Sharon Pendlebury, our Administrator.
Good morning.
And today we are going to be presenting on Cluster B personality disorders. So the objectives that we're going to be covering today is really to provide an overview of the diagnostic criteria for Cluster B personality disorders, give some information about the characteristics and treatment for Cluster B personality disorders, and then talk a little bit about the suicidality of Cluster B and provide some helpful hints when working with this population. So I'm going to go ahead and start with talking about the definition of personality disorders. This comes directly from our DSM-5 manual, and all of the information that we are going to be using today, all the diagnostic criteria, comes from the DSM-5. But a personality disorder is an enduring pattern of inner experience and behavior that is different from the individual's culture. It's pervasive and inflexible. It has typically an onset in adolescence or early adulthood. It stabilizes over time, but it leads to significant distress and impairment in one's social and occupational life. So the clusters in general, there are three clusters. The first one, cluster A, can be classified as the weird or the eccentric. This is your paranoid, schizoid, or schizotypal. We have the cluster B, which we're going to focus on today, which is the wild. These are our antisocial, our borderlines, our histrionic, and narcissists. And then cluster C is the worried. So this is your avoidant, dependent, and obsessive compulsive. So we're going to go ahead and start with antisocial, and I'm going to turn it over to Sharon to start us off.
Thank you, Heather.
Yes.
So, the cluster B personality disorders are the personality disorders that often come to our attention during treatment, either outpatient or inpatient or in the emergency room. People who have these personality disorders tend to be more risky than the cluster A's and the cluster C's, both to themselves and sometimes to others. They tend to be more impulsive, and so they tend to draw attention. And so, therefore, they come into treatment, and maybe with comorbid mood disorders or anxiety disorders, but basically we see them more often than the other clusters, which is why we chose to talk about them. Antisocial personality disorder is one of the cluster B personality disorders. The definition in the DSM-5 is as follows: a pervasive pattern of disregard for and violation of the rights of others that begins in childhood or early adolescence and continues into adulthood. Deceit and manipulation are the central features. This pattern has also been referred to as psychopathy and sociopathy. We'll talk a little bit about that later. Motivation for coming to treatment usually involves somebody else pressurizing somebody to do that for change. It's usually either the criminal justice system or there's financial leverage. There's a problem with relationships secondary to the deceit and manipulation, and there's some financial reason for that person with antisocial personality disorder to engage with treatment in response to that leverage. Or they may come into treatment in order to meet a comorbid need for substances. It isn't a great start for treatment because the investment is rarely there and the insight is rarely there. People with antisocial personality disorder are your straightforwardly the kind of petty criminals that go in and out of jail. They steal, they lie, they need to get what they want, and they have very little empathy and very little conscience, which is characteristic of this class. They really need what they want when they want it. They won't hurt you unless you get in the way. They have no objection to hurting you, on the whole, if you get in the way, but they don't particularly enjoy hearing you scream. But getting in the way would not be tolerated. And if they have to use emotional force or physical force in order to get what they need, then they're quite happy to do that. The criteria for antisocial, therefore, is failure to conform to social norms, repeatedly performing acts that are grounds for arrest. People with antisocial personality disorder do not plan. Most cluster B personality disorders do not plan. They're fairly impulsive. They don't think easily of consequences. They live in the moment. That frontal lobe piece is not well developed, if developed at all. So your planning, your empathy, and your conscience that sits here is underdeveloped at best. So they tend to do what they want to do in the moment and then get into trouble for it and then do it again. Often deceitful, quite happy to con you or lie to you for personal gain. Impulsive, reckless, irresponsible. They kind of live to their own tune, and that means that the boundaries that normally surround our behaviour in a mammalian society, you know, we're community animals, that's why we have laws and mores of behaviour, and that's what works for us. The cluster B personality disorders are not attuned to any of that. They're attuned to getting their needs met and getting people out of the way or recruited into supporting them to get those needs met by whichever means available. So they do lie, and they do con, and they do manipulate, and they might hurt you. This personality disorder might hurt you, but not because they enjoy it. Usually just because it's a means to an end. Lack of remorse. You really need a conscience to be remorseful, and cluster B personality disorders tend to lack one. And so it's very hard for them to feel sorry, and they don't really understand the concept. They're your kind of reptilian brain. They're not your mammalian brain. And the difficulties people have with that is that we project ourselves onto others. When you meet somebody, you assume they think in the same way that you do, that their brain has developed the way yours has developed, and that makes you very, very, you have a huge tendency towards altruism, you have a conscience, you have empathy, it develops, you'll do things for the good of others, and you don't always see others as servants to yourself. Cluster B personality disorders don't have that brain. It's a different brain. And once you know that, you'll know much better how to support them and keep them safe and everybody else safer. In order to meet for antisocial, you'd have to have a history of conduct disorder by the age of 15. This thing starts late childhood, early adolescent, becomes very apparent. We have a psychopathy checklist here. Psychopaths are a little different. They're kind of the other end of this scale, although they come under the same diagnosis. Psychopaths like to hear you scream. Antisocial personality disorders will hurt you if they have to. Psychopaths like to hurt you, either emotionally or physically. And so they can be dangerous, but they're rare. They're rare. Your bog standard antisocial personality disorder occurs much more frequently. Psychopathy is a very sophisticated form of this disorder, and it doesn't happen often. So a psychopathy checklist. People are charming, have to learn to live in the mammalian world and survive in a community setting when they're not community animals. So they learn how to groom. They learn how to be charismatic. They learn how to be charming because they need you, your prey. They need to reel you in to get what they need from you until they don't need you anymore. And so they're very, very good at establishing very quickly those relationships that often would take much longer with a normal pathology. Very grandiose, they're narcissistic, they think they're wonderful, and also that gives them some protection from the anxiety that might go alongside their impulsive behaviour. They get bored easy, really easy. They kindle low because it's that reptilian brain again. You kindle to hunt, you kindle to hunt. So they kindle here all the time. Content is not a word that they would understand. They tend to be conning and manipulative, have a shallow affect. They'll speak to the audience in whichever situation they find themselves to get what they need from you. We all manipulate our environment to get the best out of others. But those of us who do not suffer from lack of consciousness or lack of empathy have that altruistic element, which enables us to do things that are fair and just and that be treated as we would like to be treated, if you see what I mean. There is no investment with the psychopath in that. Tend to be parasitic. Why do the work if somebody else will do the work for you, right? Poor behavioral control, get mad. They can get really mad and really, really disguise it. Their anger is they're past masters at disguising anger, but it's there and they get angry quickly. Lack of realistic long-term plans. These are not planners, these are reactors, just like the other cluster B personality disorders. Impulsivity and irresponsibility, and they're very criminally versatile. So basically, you have the reptile swimming in the mammalian pond. It's just unfortunate that the other mammals don't tend to recognize that until it's fairly well established, and that can be too late for some. Treatment. Overall treatment for antisocial personality disorder is fairly pessimistic in terms of outcome. In order to get treated, you really need to have some level of insight and motivation. Your antisocial personality disorder, much like your narcissistic personality disorder, thinks they're the norm. So if you can sit long enough to hear what they're saying and get them to talk to you without judgment, then they would tell you that all of this rubbish about either being a sucker or a predator is our rubbish. In other words, you're just like me and you're lying about it. You're just better at this than me, and you look better and you groom better, but you're exactly the same as me inside. Or you behave like this community animal that's fair and just and understands the concepts of partnership because you're stupid. So you're either lying or stupid, but what you're describing to me, I don't recognize. And they honestly don't recognize it because that's not the way their brain works. That's kind of like asking the crocodile to act like the elephant. That's not going to happen. Neither their brain structure, nor their DNA, nor their neurochemistry is enabling that. It's a different world. And it's the world they're living in. And they can't understand or appreciate where the rest of humanity is coming from. But they serve a purpose. We serve a purpose. So, treatment is hard. The improvement of moral and social behavior, you can help that with some cognitive functioning. Certainly as the antisocial personality disorder patient gets older, they tend to burn out a little bit. They start thinking that spending long periods of time in jail is not a good thing. They've had enough consequences, that their impulsivity is lessening with age, that sometimes they can use that as a starting point, and you have some leverage for therapy with that because it's in their own best interest. When they're younger, you're probably not going to be successful. Set clear limits if you're involved in treatment. Keep therapy structured. At the end of the day, they're players. They'll play their therapist just like they play everybody else. And it takes really skilled therapy. I mean, therapy is quite boundaried anyway, but it takes really skilled therapists to be able to work with this population because they need to know what they're looking at, and they need to treat to what they see, not what they would like to see, but the capabilities of that personality in front of them, and set realistic goals and expectations for outcomes. Engage in a thorough discussion of life history, review additional sources of information. It's really important with the cluster B personality disorders. They are not their own best historians. They have no attachment to the truth, none of them. None of the four of them have any understanding of why anybody would tell the truth in a situation where it does not benefit them. So they're very unreliable historians. You'll get a much better history from collateral, maybe formal or informal collateral, professional collateral, as well as family. You usually don't have too many friends. unless the friends are meeting their need at that time. But as much information as you can get from other sources, the better picture you'll get. And then work to identify cognitive distortions. Wanting something justifies the means, justifies the ends, right? Or there won't be any consequences. When you actually get to the point where somebody will engage in therapy, they're usually older, pretty burnt out, and they're fed up with the consequences, and that's your leverage. So you have to work with them to learn how to challenge their own distortions that have been lifelong. It's okay saying it doesn't matter, nothing will go wrong this time. Let's look back at when things went wrong last time, and the time before that, and the time before that, and the time before that, and what the consequences were for you. If you have got any leverage, that would be it. Don't seek to get the patient to feel differently about past behaviours. No conscience, no empathy. Don't try and build that. It doesn't exist and it never will. What you're trying to build is community behaviour compliance based on avoidance of consequences. That's what you're trying to build. Don't set expectations for the development of a personality that is never going to be there. Okay, so that's antisocial personality disorder. Now we thought we'd talk about narcissistic personality disorder. Narcissistic personality disorder is defined as a pervasive pattern of grandiosity, the need for admiration, and a lack of empathy that begins in early adulthood. Narcissistic personality disorder is kind of the common understanding is, I love me, who do you love? Actually, a narcissist's entire personality is built on anxiety. These patients have a hugely dense core of ego anxiety. They cannot tolerate being challenged. That causes ego disintegration and therefore identity disintegration. They have to have the best. They have to be the best. Even if they're not the best, other people have to tell them that they're the best. They need that supply. They will only deal with somebody who's in authority. They will only listen to somebody who has status. All of that is all about self-soothing. They're at their core the most anxious of the personality disorders, even more anxious than the dependent personality disorders in cluster B. And they will mitigate that anxiety no matter what the cost. It's absolutely imperative to them that they are able to soothe that quaking rock in the middle of their being all the time. And the way they do that is by being grandiose, by being entitled, by dealing with people that they think are going to support that for them, and by not tolerating anybody who questions them. They're not able to do that. Their pathology won't allow them to tolerate it. What makes them the most dangerous of the personality disorders is that they are almost always really, really tied to revenge. If you have wounded a narcissist, and you can wound a narcissist pretty easy, you may just be pointing out that it might be better to do something a different way, but you may not be chairman of the board who's doing that. You may just be saying, no, unfortunately we can't do that for you today, sir. It doesn't take much to wound a narcissist. And once wounded, the way they repair their ego is to punish you. And they almost have no choice about that. A narcissist, revenge is a dish best served cold. And until they come for you, they can't settle down. And that makes them dangerous. You have to be really careful. Especially when you're in a treatment environment where we would normally set pretty strict boundaries, and that's not going to change for the narcissist. But we know how little they will tolerate that. And we need to have plans for enabling them to remain engaged without sabotaging their therapy, without sabotaging their treatment, and without becoming the focus for without becoming their victim, essentially. So, personality disorder criteria. They have huge vulnerability in their self-esteem. It makes them very sensitive to injury. A wounded narcissist is not a happy person. Once they're wounded, they're coming. They might not come today, they might come tomorrow, but they're coming because it's the only way they can restore that ego function. You have to be in the wrong and you have to be punished because you've wounded them. What they need is supply, total, unrestricted, unconditional admiration. That's how they blossom. And the minute it stops, you have a very different animal. So, usually they're grandiose, they have a huge self-importance belief, they expect to be recognized. Again, they're usually extremely charismatic because they've spent half their lives developing tools that enables them to get the supply that they need, and so they're very good at working the rest of us. And they work hard. They work hard to get what they need, and they get very angry if that is upended in any way. Preoccupied with fantasies of success, power, beauty, love, believes they're special or unique, and they have to believe they're special or unique because they're so anxious inside they couldn't tolerate it if they weren't special or unique, and should always associate with others who are special. They like excessive admiration. Nothing is too much for the narcissist. It's making you feel like somebody's got to pass the vomit bowl. They love it. Absolutely soak it up. They will take that all day, every day. The minute you'll have a problem is when you say no. They will not tolerate no. They might tolerate no from the President of the United States without showing their anger. But if it was me that was saying no, or you that was saying no, they may be pleasant to your face, but that revenge is coming, and coming quick, because you don't have near enough status to support that sabotage. You just don't. They take advantage of others. They have absolutely no conscience and absolutely no empathy. And they're envious of others and believe that others are envious of them, and of course quite rightly they're envious of them. And they tend to be pretty arrogant. They are not rule keepers. None of the cluster Bs are rule keepers. But narcissists can do really well if they're high functioning. They can be CEOs or COOs. They get to the top because they're not looking back and they don't care who they're hurting. And they absolutely need to be there. That need for success and need for supply dominates their entire life. And so if they're functional and intelligent and charismatic, they can do well. If they're kind of mediocre, you tend to see that they do well in a setting. They get recruited, they'll do great, everybody loves them, they think they're marvelous. Somebody says no, and it all goes to hell in a handbasket because the revenge starts. It's inevitable. And then that usually gets them into quite a lot of trouble. And then they get fired. And then they go somewhere else. And they'll start again on that kind of little wheel. And then somewhere else. Really outstanding narcissists can get to the top, earn a great deal of money, and stay at the top for a little while. But they have to be sophisticated. So usually with a narcissist, interpersonal relationships are impaired because of the problems of entitlement, the need for admiration, and the disregard for sensitivity of others. The only way to be in a relationship with a narcissist is to give them absolute supply. They will not tolerate dissent. It won't be allowed. So you have to be somebody in a relationship with a narcissist who is always going to subjugate your needs to theirs. Always make it clear how much you admire them. Always stand on their side, on their perspective. The minute you even seem to be cracking, you're done. Ambition and confidence can lead to high achievement. However, performance may be disrupted because of the intolerance to criticism and defeat. The minute you say no, they're coming. They cannot tolerate it. And that gets really messy in an organisation quite quickly, and then they move on. They're snobbish. They tend to devalue the contribution of others. These are not people that attribute success. So it wouldn't be, we had this great program because Jane and Heather and Dawn got together and look what they did. That is not going to happen. What's going to happen is, look what I did. Who's Jane, Heather, and Dawn? Who are those people? That's a narcissist. And they tend to discuss their own concerns in an appropriate and lengthy detail while failing to recognize that others have feelings and needs. 50 to 70% are males. I have seen some fairly decent narcissistic females, but the really superlative narcissists that I know or have treated have all been males. Treatment. They're usually seeking for another diagnosis because there can't be anything wrong with them, right? There can't possibly be anything wrong with them because otherwise they're going to pieces. Their entire being is focused on making sure that there is not one element of a suspicion that there's anything wrong with them. They will not take criticism. They cannot tolerate it, so there's no point trying it. Be clear about limitations and rules. Obviously, your narcissist will ask if your therapist went to Harvard. If they didn't go to Harvard, they will ask why they're seeing them, even if they're the best therapist on the planet, because Harvard's important, right? Find ways to cope with their negativity. The negativity is about everybody else, it's not about them. They have very low arousal tolerance, and they have very low tolerance for anybody else's opinions, views, lifestyles. Everybody else is just prey, essentially. Meet my needs, meet my needs, meet my needs, meet my needs. That's the only thing you're useful for. Meet my needs. And this is how you do that. You do that by being nice to me, telling me how wonderful I am, getting all obstacles out of my way, and stroking my ego. That's how you be nice to me. Identify automatic thoughts and creating balancing statements. Just like all other cluster Bs, narcissists develop automatic responses, and it serves them well. It would be very difficult to get a narcissist to challenge those willingly. If they were going to lose either status or money big time, they might tolerate the process. Honestly, never seen any of them invest in it. So be careful when you're working with somebody who has an established diagnosis of narcissistic personality disorder. Just be careful. Make sure you get a lot of support, make sure you get a lot of supervision, make sure that you partner up, and make sure you give away little to no personal information. Because it's almost impossible in a healthcare setting to always say yes. And that's inevitably going to lead to trouble. Okay?
Great. Next, we're going to talk about borderline personality disorders. So for the borderline personality disorder, most of us are familiar with this particular group, and we have seen these patients on the inpatient side. We see these patients in the emergency department. We see these patients on the outpatient side. And so out of all four of the clusters we're talking, or individuals in cluster B that we're talking about today, borderline personality is probably by far most of the one that we're most familiar with. The diagnostic or DSM-5 definition is really the feature is the pervasive pattern of instability of interpersonal relationships. That's really one of the key features for the borderline personality disorder, is that inability to really maintain their interpersonal relationships. They often have trouble with their self-image and regulating their affect, and there's a lot of impulsivity that's associated with this, that's beginning in early adulthood. And is really present in a variety of contexts. So we see these individuals usually during times of crisis. That's usually what brings them into treatment. These patients typically are not coming into treatment for borderline personality disorder. They're often coming in because something else has happened in their life or for another diagnosis. And so that's what makes this group really difficult to treat is because they come in during that crisis. Once the crisis has resolved, it's hard to keep them engaged in therapy or in treatment, and that's when we often see them leave treatment and then come back again when there's another crisis. Yeah. So the diagnostic criteria for the borderline is as follow. There's real efforts to avoid real or imagined abandonment, and many of these individuals really have experienced some significant loss and abandonment in their life. However, they really translate that to many of the other relationships that are happening in their life, and that might even be with their therapist, is this real fear of being abandoned by their therapist. Intense unstable relationships, identity disturbance, impulsivity that is potentially self-damaging. Often we're used to seeing these patients because engaging in really reckless behavior or binge eating or spending sprees, substance abuse, just because of that impulsivity. Recurrent suicidal behavior, self-mutilation. These are our cutters. So these are the ones that are not necessarily cutting because they're suicidal. They're cutting to escape their emotional pain by trying to feel that physical pain instead. This, of course, makes treatment difficult, and assessment in the emergency department can be difficult because their intention may have been to really just self-harm, and they cut too deep or something happens, and really it's the PART team is having to assess that as a suicide risk. Affect instability. Again, these individuals have a really difficult time really regulating that emotional thermometer. So they are up and down and kind of all over the place in managing their emotions. Real intense or inappropriate anger. These patients we may have seen, certainly an outpatient might blow out of treatment. It's very dramatic. They might slam doors. They escalate very quickly. This may occur in the inpatient unit too. So their anger, their emotions kind of go 0 to 60 really quickly. They have a hard time kind of working in that shade of gray because they're constantly looking at things as very black and white thinking. So again, kind of how Sharon was talking about the inability to tolerate no, this group is going to have that difficulty as well. Stress-related paranoia, and in some case, real dissociative symptoms. Again, many of these individuals did have a traumatic childhood, may not have been validated as a child, and so there is often a very large component of trauma and abandonment that may be occurring that's real, and so they are experiencing that. The characteristics of the borderline personality patient is really, typically we see this diagnosis among females, although not always, but about 75% of the time it is a female diagnosis. Lack of clear sense of identity results in a lack of clear goals and poorly coordinated actions. They really, because they can't monitor their emotions, because they can't really regulate, and because they're so impulsive, they really can't coordinate real appropriate responses to situations in the environment around them, and that's what tends to get them in trouble. Of course, we know that they have frequent crisis calls, so this can be really exhausting for caregivers and certainly for their family members. Because if they're not calling us, they're probably calling someone else in their life, and that can be really exhausting. There's this tendency to really idealize or dislike others, so that can be really difficult, again, for family members and for therapists or a treatment team, because sometimes we are great, we're the best therapist ever, and then the next session we are terrible and
love you, I hate you,
that's
I hate
right.
you, I love you, I love you.
Yes, so it's this back and forth, I love you and I hate you game, and so that makes it really hard to maintain those relationships, which is why they tend to kind of go from relationship to relationship to relationship, because they can't maintain that relationship, they can't repair it. Real dramatic overreactions. Again, just not able to manage their affect and regulate their emotions. Self-destructive behaviors. Again, these often result in landing in the ER or the inpatient unit, or damaging relationships in their lives, losing their job, all those kinds of things. And again, just to really reiterate that the characteristic of this group is that there probably was a real lack of validation in their early childhood and some real serious abandonment and loss that happened. So this group is really doing the best that they can, and they're really trying to respond to the environment around them, but they really haven't developed the skills and the interpersonal functioning to do that very well.
One of my lecturers once said that people with borderline personality disorder may be chronologically 50,
right,
but they're emotionally 3.
Right.
They never internalized their own parent. They never were able to become their own mother or their own father. And all of us do that,
Right.
But they didn't. And so all of that outrageous behavior, the self-destruction, the impulsivity, the I love you, I hate you, I love you, I hate you, if you put that in the context of a 3-year-old tantrum, then you have somebody with borderline personality disorder that's trying to function in an adult world. And that's really, really hard. And they do badly because of that. Because nobody wants to parent a 50-year-old who acts like a 3-year-old. And that makes it very hard to be that 50-year-old because everybody else just keeps abandoning them because they can't cope with them. That's a very difficult place for somebody with borderline personality disorder to be.
Right, and that abandonment that happens throughout their life is because they are very difficult to have a relationship with, and so they perpetuate that belief system that they are going to be abandoned because they are. Yeah,
they never grow up.
They are abandoned.
They never internalize their own parent. That never happened, and we rely on that happening to be functional as adults. We don't need to have everybody else make our decisions for us, make it right for us. We don't need to have everybody else manage our behavior, corral our emotions, because we've kind of learned how to do that ourselves,
right,
from our carers, whoever they were. And we've internalized and watched it and modeled it and practiced it. And by the time we get to our early 20s, we're usually pretty good at it. We never did that. So they're chronologically 50 and emotionally 3, which is disabling.
Right, right. So for them, the world is, unsafe and unpredictable, and so they're responding to that out of that lens.
Yeah, absolutely.
And so when we look at the treatment for the borderline patient, we're really looking at skills training and using DBT, which is the dialectical behavioral therapy. Most of us are familiar with this because it is the modality that we use on the inpatient unit, and then we extend that to the mental health IOP program after inpatient or as a step down, or avoiding a potential hospitalization. And so this is really an intensive program that really is focusing on how does the individual better regulate their emotion, how do they maintain their interpersonal effectiveness or increase their interpersonal effectiveness, distress tolerance, how are they mindful and more aware of their actions so they're not so reactive. So all of the skills training is really focused on what they can do in the here and now to better cope and manage the environment around them and better manage themselves in the environment around them. And so we don't do a lot of talky processing in that type of a group because we really want them to practice a skill and learn that skill and be able to use that skill outside of the clinical setting. And so this kind of gets away from, because if you let them talk too much, that's going to get into diving into places that they really don't have the capacity to really I'm trying to think, they really have the capacity to deal with, because they don't have they're not that sophisticated, they're not that resourceful yet, and so we have to be able to give them skills to manage difficult situations, which for them is most situations that they're in. And so this is really scary for the patient because we're really asking them to unravel everything that they know to be true about themselves and about how they see the world, and give them a different set of tools to use, and to really start seeing the world differently. And so that can prompt a lot of anxiety for this patient. And so we need to make sure that we are empathetic to that. We also need to make sure that with this particular patient that we're not sharing a lot of our personal selves as clinicians. And really the reason why is because they constantly have that love-hate relationship, and we don't want them to feel like they have to take care of us or that they need to worry about us, because for them, they're going to internalize that, and that's going to become a big focus for them. So we need to make sure that we're very clear in setting boundaries and expectations of what therapy looks like. We also really need to help the patient look at their dichotomous thinking, because this patient really sees the world in black and white. So it's all or nothing thinking, and we really need to help them see the world differently or be able to kind of function in shades of gray. Just because someone said no doesn't mean that they hate them. So it's really validating the patient and setting limits. I know we hear that a lot, but that's because that's what works for this patient. And then also in treatment, we definitely really want to make sure that we're managing that self-harming behavior, and that really an expectation for the patient is that if they're committing to treatment, they're going to be committing to not be doing that self-harming behavior like cutting, that they're going to be working on utilizing different skills instead of the cutting behavior. So we're trying to take away their natural coping skills, which again, they're doing the best that they can. They're coping with what they know, and replacing it with something else so that they have something to use. Otherwise, they're just left with nothing. Yeah, and they're floating around. Yes. So I guess that's all on the borderline. But we will move into our last of the cluster B personality types, which is our histrionic personality disorders. And this is really a pervasive and excessive emotional individual that is constantly seeking attention. So kind of thinking that this is an individual that's kind of on their own Broadway stage of life.
They theft very well.
Yes.
They are innate theftians in extremis.
That's right. That's right. And so because they are constantly on stage, they have a real difficulty in achieving emotional intimacy.
It's all out there, isn't it?
Yes, and they are acting out different roles in their relationship. So they may constantly be the victim or need to be kind of the princess in that relationship. So we don't see a whole lot of these individuals. They're out in the world, but we don't see them a whole lot. Maybe more so on the outpatient side. But again, it's usually they're coming into treatment because of something else. They're not coming into treatment because they know that they have histrionic personality disorder.
And they can be quite charismatic, and
Right.
they're not as self-focused in terms of preying on others.
Right.
They do like attention.
They do like
however.
attention. They do like attention.
But they tend to be more charming and less malicious.
Right.
So that's probably why
They just want people to like them.
yeah, a lot.
A lot.
And a lot of people.
Right, right. So the criteria for this group is that they actually become really uncomfortable when they're not the center of attention. They don't really know what to do with themselves because they need that constant attention to feel good about themselves. Their interactions with others is often inappropriate. They may be really sexually seductive or provocative, again, because they're trying to get that attention and seek that validation. They might have really rapidly shifting expression of emotion, so really kind of extreme highs and lows, and very, again, theatrical.
Dramatic.
Yeah.
Drama queens.
Very dramatic, yes. Very, yes. Again, this group is probably going to get bored pretty easy because if something's not going on or they're not the center of attention, they're going to do some sort of, introduce some drama to make it a bit more interesting and bring themselves back into that middle of the show. They might use physical appearance to really draw attention to themselves. Their speech may even be very flowery or very expansive to really catch attention. So anything that they can do to draw attention to themselves is welcomed. Very exaggerated emotions. They might be suggestible because, again, these are people pleasers. They want attention. They want people to like them.
Bright, shiny thing.
That's right. Something bright and shiny, and they're going to follow it. They're going to maybe consider relationships to be more intimate than they really are, because they're really kind of not in touch with what's going on around them because it's all about them.
But in a rather nicer way.
But in a nice way. Yeah. Yeah.
In a more beguiling way,
right,
than a narcissist.
Yes, absolutely. Some of the characteristics of this group is that they may have difficulty maintaining relationships with same-sex friends, and that's because of just competition, and they want to be, of course, at that center of attention. So they're not going to, if they're a female, they're not going to want another female outshowing them or outperforming them.
Heaven forbid.
That's right, to look better, because that takes away, again, that attention on them, and they're going to want that attention from maybe a male instead. Again, they become bored with routine, so they're going to stir the pot a bit. Long-term relationships are often going to be neglected because they're long-term, they're routine, they're boring, and they're going to make way for kind of new, exciting relationships and kind of ride that roller coaster and see where that's going to go for a while. So again, it's kind of jumping from person to person to person.
The grass is always greener.
The grass is always
greener.
greener.
Of the fence. Yes.
What we may have seen is higher risk of somatic disorders. This is one that we have seen maybe more so in the outpatient clinic. Is it manifested in this way of that patient that has 50 medical conditions? And so that's something that we probably see more is the somatic complaints that are occurring. Trying to gain control of partners through emotional manipulation or seductiveness. This is where we might see them in the ER, is because they're wanting that attention from their partner. They're not getting it, and so then they do something impulsive. They end up swallowing some pills or something to really show that other person
how much they should love them.
How much they should love them, and then they're ending up in the ER for a suicide attempt. And so that's likely how we're going to see them come into treatment, is going to be something like that. Emotions are constantly exaggerated, and that they are very overly concerned with physical attractiveness. So treatment for these individuals, again, is pretty difficult, as with the other individuals in the cluster B group. They tend to leave treatment very abruptly. Again, they want to be the center of attention. If they're not, then that might be challenging. So a group setting, for example, might be very difficult for this individual because they're going to want to be the center of attention.
And for the rest of the group, it can really sabotage.
Yes, it might be very painful for the other members and impact their treatment. Again, kind of helping this individual look at their automatic thoughts and see how that's contributing to their behavior can be helpful. Trying to do some reality testing with this individual might be helpful, so some of those CBT skills. One caution is for the therapist to know is that the histrionic individual may really idealize the therapist or really think that they're all powerful person that's going to save them, and then might be greatly disappointed when that does not happen.
And they do tend to get, just like antisocials, they do tend to get a little burnt out with age, especially if they feel that their physical attractiveness has deteriorated.
Right.
That loses them a huge amount of leverage as far as they're concerned. So that makes life more anxiety provoking rather than, I'll just move on. Hey,
Right.
the other side of the garden is green and I'll just move over there. And I think as they get older, they're more likely to come into therapy. But yeah, when they're young, and physically attractive and being able to manipulate their environment and being the center stage, they don't usually seek out to change that.
Right. But you're right. When they're older and coming in, then tools
hard.
like the chain analysis or ways to look at kind of patterns in their life and in their behavior can maybe be helpful in creating
They'll be more
awareness
open to that.
yep,
They'll be more
about
open to
how
that.
their behavior is impacting the relationships and the environment around them.
Yeah, because they've lost some of the power and the leverage that
Right.
they had because of age, and they have to have something to replace it, and sometimes we can help with that.
Right. So in terms of suicidality and the cluster B personality disorder group, according to the American Journal of Psychiatry, personality disorders are estimated to be present in more than 30% of individuals who die by suicide, about 40% of individuals who make suicide attempts, and about 50% of psychiatric outpatients who die by suicide. So 60 to 70% of patients with, especially with borderline personality disorder, make suicide attempts. And so I think that's really important to be aware of, and that also personality disorders have other complications that are also co-occurring. So there's substance abuse that's happening. There are other mental health diagnoses. They have unstable relationships, so they have a lack of support groups, and their support network might be very tired of them. They have huge cognitive distortions about how they see themselves in the world, and so because of
They
their
don't make good decisions.
they don't make good decisions. They're reckless and they're impulsive, and so that puts this group at very high risk of completing suicide. And so I think that's really important to understand, is that the bottom line is individuals with personality disorders do complete suicide.
More often than any other diagnosis.
Yes.
And I think often what we hear in an acute or an emergent setting, they're just borderline.
They're just borderline.
Yeah, well,
they're
if
not
you-
going to kill themselves.
If you want to save lives, you need to take that borderline seriously.
That's right.
Because that person with borderline personality disorder is more likely to kill themselves than any other diagnosis in the DSM-5.
Right. Think of the multiple attempts that they're having. These individuals are going to have lots of attempts.
And sometimes they get it right.
That's right. And one time they're going to misjudge, and they're going to drive too fast, or they're going to
Somebody
take too
won't
many
come
pills.
back.
They're going to call, and someone's not going to come back, or something's
They've
going to happen.
overdosed. Yeah.
And so I think that because they tire the group, the support network around them, as well as professionals,
Yes,
we can potentially miss
That dangerousness.
how dangerous these individuals can be. So I think that's really important to keep in mind. Some helpful hints as well is that patients are truly doing the best that they can. We know that this group is exhausting, and so we need to make sure that we're not reacting and responding to that patient because we're exhausted, and maybe we've seen them in the ER 100 times, but they're really doing the best that they can.
It's
and they're trying to
pathology, not
change.
character.
That's right.
It's pervasive pathology. It's difficult to change, and it expresses itself in what we would normally interpret as characteristics, but it isn't character. It's pathology, and
Right.
it's consistent and predictable,
Right.
dependent on diagnosis, just like diabetes is or hypertension is. However, the impact cluster Bs can have on both their own lives and especially the lives of those around them can be enormous. And so we often need to be taking care of those around them as well as them themselves. And that
Right.
includes their therapists and their psychiatrists. This is not an easy group to treat.
No.
And most of the people that are treating them do not have a personality disorder and don't have the relief that a lack of conscience and a lack of empathy would give a cluster B personality disorder.
Right. And so just recognizing and keeping in mind that patients really want to create a life worth living, and that's why we are seeing them. They're in pain.
A lot of pain.
Yeah, a lot of pain, and they are coming to us because they do recognize that they need to change. They just don't know how, and so we need to make sure that we're helping to give them the skills to do that and better function in the world. And so
maladaptive solutions.
right.
And it's so entrenched, and it's very difficult for them to understand that in the moment. Just as it would be for any of us if we inherently reacted to our internal parent. If we didn't have one, we would inherently react without it.
Right.
And they all suffer from that.
Right. So just making sure, again, that we're not being dismissive because we see the diagnosis. We need to make sure we're seeing the individual and being professionals and not dismissing just because they're borderline. Some other helpful hints in terms of boundaries. Again, we say this all the time, we validate and we set clear limits. We need to make sure that we're being consistent so that we're not allowing them to split team members.
Be good parents.
Be good parents, that we are aligned with each other as team members, that we're being very clear when we're communicating our expectations to the individual. We need to really make sure that we're not trying friend therapy, that we're not trying to build rapport and be friends with them, that we're really here to teach skills and help them practice that and use those when they leave our care. We need to really make sure that we stick to anything that's agreed upon. So if we say something's in place, we need, again, be consistent to that agreement and really be non-reactive. These individuals are already so overreactive and can't regulate their emotions. We know they go 0 to 60 really quick, that we need to make sure that we're presenting very calmly and consistently. Self-care for us as professionals is really making sure that we're not personalizing what they may be seeing and what they're doing. We don't want to personalize them or personalize it, because often when we see them, they're in a moment of crisis and they may say and do things that they truly don't mean. And so we need to make sure that we are seeking supervision and consultation if we're really struggling because of an interaction that we may have had with that patient. Because we are human, and so sometimes we get hurt by
a lot of supervision.
Yeah, we get hurt by what someone says, and we can internalize that, and so that's why we need to really seek out that support if we're feeling that something that was said was hurtful to us. We need to be realistic about our expectations. We need to know our own limits, practice empathy, and really not make assumptions about patients and think that we know them better than they know themselves. They are truly the experts in who they are, and we need to help support their process.
And they will reveal themselves. If you know what you're looking for and you're clinically astute, you can see, you know what you're looking at. And you don't have to take a hammer to crack a nut. You just have to watch.
Right.
Take a really good history that doesn't just involve the patient, because
right.
you're not going to get a really good history from them.
Right. Any of them.
No, not really any of them. And just watch and learn. They'll show you exactly who they are, and that will help you understand exactly what they're struggling with, because these are very defined, entrenched pathologies, so they're predictable. And just like other illnesses are predictable, once we know what we have, we kind of know how to treat it if they'll allow us to.
Right.
And with the cluster Bs, that's always the catch. Are they going to allow you to work with them? Can they tolerate it? And it's usually not until they're significantly older that they're going to be invested in changing. And then you just have to do a lot of education with the people, with them and the people around them, and be very transparent, and set up some safety guidelines. Because, they cannot be who they are not.
Right.
They can learn how to be functional with who they are. That takes a lot of self-discipline. Right. But they can learn how to be functional with who they are. But they cannot transform into your mammal. That would take completely recreating that personality.
Right.
It can be done. There are some There are some communities, certainly in Sweden, that have had good outcomes, but you're talking 15 years of therapy, and I mean intensive therapy, Freudian, really psychodynamic therapy that we would never do nowadays, that nobody would ever pay for. But yes, you can do it, but you basically are taking that 3-year-old and starting again. And with narcissists and antisocial personality disorders, you're probably not going to have success. With borderline personality disorders and the histrionics, you may.
You may.
Yeah, you may. And they'll learn, just as you and I learned, how to become their own parent through training. However, that's a very intensive, very labor-intensive and time-intensive process. And most people don't have access to that.
Right.
So we do what we can.
Right. Well, thank you. This has been a presentation on cluster B personality disorders. Ta-da. Ta-da. Thank you.
Thank you.